Hello, my name is Sarah Darknell, and this is our case for the 2019 Missouri AHEC Collaborative Case Competition, and our team is Mission Possible. So the first thing we did was identify Henry's needs. His needs include in-home assistance, transportation help, referral to assisted living, financial help, COPD and dental, smoking, losing weight, and depression. So some of the resources for ADL includes in-home assistance. In-home assistance include caregivers, RNs or LPNs. They come in through third-party companies, and most of these are covered by insurance. There's a list of third-party companies right here. It's important to consider the needs of both the patient and the family members and caregivers that are normally there to help. Family members may not be able to provide the needed care for their loved ones and identify that they need help, and that's okay, that it is okay to ask for it. The patient and the family should be comfortable with someone coming to their home if they wish to pursue in-home assistance. And we think this is a good option for Henry because his daughter lives far away and can't be there all the time, and his wife is not as mobile as she once was. Another thing is transportation help. Mr. Williams and his wife cannot get around as well as they used to be, and there are 3 different transportation companies that are willing to help him out get to church and medical appointments. Referral to assisted living, this is a good consideration considering he's having exacerbation of his COPD and they're not able to get around by themselves. So if they're not wanting to do in-home help or transportation care, they can do assisted living. And there were 3 different options that I found in the Poplar Bluff area that were assisted living areas that they could look into. A social worker could help them with that.
Mr. Williams has a history of hypertension, recurrences of acute bronchitis and other infections that require antibiotics, COPD, asthma, as well as congestive heart failure, among others. He's recently suffered acute medical distress with a COPD exacerbation that required inpatient treatment. Pneumonia was ruled out, but he was initiated on a short course corticosteroid therapy and referred to pulmonary rehab upon discharge. Our goal is to improve the patient's immediate COPD management to prevent future infections, pneumonia, as well as recurrent hospitalizations. We want to avoid putting Mr. Williams, who already has a history of infections, at a higher risk, and we want to avoid adding stress to Betty and Eartha about his care. I will discuss the most acute pressing need for the patient, COPD management, and appropriate measures to take. Number 1, refer to dental care. Improved oral hygiene is associated with decreased rates of pneumonia, COPD exacerbations, as well as overall respiratory tract infections, all of which the patient has a history of and is at risk for. The patient does report dental phobia as the cause of this hygiene, and this will be addressed in the long-term care. Number 2, we want to manage and monitor the patient while they're in rehab. Looking at improved mobility, exercising at least 1 to 2 times a day, O2 supplementation to determine if the patient's at goal or if he will need long-term care, as well as looking at immunization history as the patient is a candidate for pneumococcal vaccines as well as the influenza vaccine. Number 3, medication management, education and adherence. Patient uses inhalers and nebulizer. It's important to revisit the inhaler use technique and adherence, as well as note the frequency of use, especially for his short-acting inhaler. We want to educate the patient on the do-and-up that he received upon discharge, as far as maintaining the nebulizer, cleaning it, how to use the machine, and to make sure to use it accordingly. It's important that the patient finishes out the course of corticosteroid therapy, even if they start feeling better. Want to make sure Mr. Williams takes it with meals, takes it during the daytime to avoid staying up at night, and to report any recurrences of edema or muscle weakness to the attending provider. Number 4, smoking cessation. The patient has expressed interest in quitting smoking, and in fact, smoking cessation will improve his other comorbidities, including hypertension, heart failure, as well as preventing future infection risks. We can tackle this non-pharmacologically by looking at behavioral and habitual changes we can make, like removing or avoiding triggers that could prompt him to smoke, replacing the smoking habit with a new habit when the cravings occur, looking at psychological changes, using positive self-talk, encouraging him to think of Eartha and keep a picture of where he'd usually keep cigarettes or other triggers, as well as reminding himself who he wants to get healthy for. As the patient does report geriatric depression, we could consult psychiatry for this. Our pharmacological methods would include nicotine replacement therapy. This would be more affordable, like lozenges and gums and patches, than Chantix, though the patient may be eligible for that through a manufacturer program.
Hello, this is Sherri Runde, and I'm going to be talking about the long-term needs of Mr. Williams. Some of the topics in the long-term needs were addressed in the acute and the short-term goals, but I feel as though they will flow on to the long-term needs. To start with, some of the long-term health needs would be finding a dental provider so we could work with Mr. Williams on his dental phobia, improve his oral health, properly fit his dentures and his partial dentures, maintain a scheduled routine for his visits, and go over his medications needed for inflammation, dry mouth, and yeast infection, and provide him information for oral cancers and monitoring his oral health. Next would be his health education, where we would provide him with information on his health and disease processes, including his symptoms, prevention, and treatment processes. Give him information on exercise, improving his tolerance, range of motion, and implementing rest periods, implementing smoking cessation and abstinence, and also look at his exposure to dust, fumes, gas, and smoke. Give him information on his medical information, his compliance, use, treatment used in emergency situations. Also looking at his nutritional needs, his supplements, his COP diet, his food consistency, and following up on his swallowing. We would also be addressing his anxiety, depression, and getting involved in support groups. We would be looking at his therapy goals. That would be your occupational, physical, and respiratory, where we would be looking with adaptive equipment in his home, safety of his home, endurance with his ADLs, increase his mobility, continue working on his breathing techniques and energy conservation, and look into home oxygen machine. We would be looking at improving his strength and endurance, improve his balance and fall safety, providing information on exercise and mobility, improve his sitting tolerance and distance walk, and include the proper use of his walker. We would also be monitoring for his respiratory system, the rate, rhythm, depth, and effort. Give him education at home on his oxygen machine and nebulizer treatments, education on his effective coughing and deep breathing techniques, use of his incentive spirometry, his position of comfort, controlling the temperature in his home so there's not extremes of heat or cooling, and work on smoking cessation and his environmental pollution. With his long-term personal services, we would be looking into home health services, which would help with monitoring his medications, nutrition, and well-being, provide assessments of his medical, emotional, and physical needs, and provide continuing information and assist with referrals and follow-up needs. We would also be looking at the Senior Circle program there locally, which would provide health and lifestyle information and services, and discounts and perks. Additional support would be the Northside Nutritional Center, which offers Meals on Wheels, exercise and educational programs, along with holiday, musical, and monthly events. We were looking into trying to get the family moved into the assisted living housing, where they would have assistance with their ADLs, and it would also be a secured, safe living environment with staff on site. We would also be looking at area transit services to provide transportation for Mr. and Mrs. Williams to their church, medical, dental, and health appointments, recreation and ladies groups, support groups, and their volunteering activities. Another additional support would be using the social worker to help with referrals to various healthcare providers, assistance with all the forms to be filled out, referrals to available community resources, some financial supports and referrals, family and caregiver supports, and along with mental health needs, support groups, counseling, and any cultural barriers. We would also be looking at nutritional support, where we would be trying to increase his fluids, look at the consistency of foods, any barriers, supplements needed, follow up on his swallowing, and also a COP diet and implementing rest periods. With our IEP team, we will be going over the roles and responsibilities of all the members, where we try to have effective teamwork, communication, where we're using the expertise of our team members, where we're going to try to increase the patient's safety, adapt to his unique culture, provide all education and teaching that are needed to where we have a calm, trusting environment. We're going to help the patient with his coping and stress, which will also help with the family, the patient, and the wife. We want to make sure that we're having good communication skills between all our team members, so we improve our care and we prevent errors. We increase our patient satisfaction, and we're enhancing the patient safety to where we're improving his lifestyle and giving the patient his individualized patient-centered care. Thank you.